Good. All right. Anne, whenever you want to go, if you want to introduce yourself.
Sure.
Everyone knows you, though.
I am honored to be part of this journal club. I'm Ann Lee. I'm one of the dietitians at the Celiac Disease Center at Columbia, and I have the opportunity to share some of the research we've done, but highlighting in particular the article that Megan shared on the hypervigilance study that we have done. So what we're going to do is do a little bit of background first, kind of look at the different areas that celiac disease and the gluten-free diet do impact, and then importantly look at some solutions and treatment which should launch us into the information that Vanessa is going to share next. Okay, so with that, we kind of look at quality of life as a background, and why has quality of life studies really been kind of a focal part and a real center pin of a lot of research done in celiac disease. And it's really because it's multifaceted reasons where the only treatment is a highly restrictive diet, and there has historically been poor availability of quality and poor quality of products. And when we think of diet, it impacts so much of our life and really can be that cornerstone. What we're also finding is that the impact is universal, that we're really seeing similar findings around the globe now, which was not the case several years ago. When we look at the impact too, it's important to kind of measure the impact of celiac disease and the gluten-free diet compared to other illnesses. And celiac disease is only second to end-stage renal disease when we look at the impact of diet and the disease and treatment on a person's individual life. And that says a lot in terms of the degree of that negative impact. When we look at what that impact is, we need to pay attention to that global aspect of the impact. And when we look at celiac disease and the gluten-free diet, we really see that it covers all of those domains. There's worry about the future health, your future health. It impacts work and sick days, relationships, cost, fear of symptoms, access to food, and even a feeling of being alienated from health services for many patients. What this boils down to is we're going to kind of highlight a couple of these key points. We're going to look at the economic impact, the nutritional quality of the gluten-free diet, then overall quality of life. And we'll go through these quickly because I'm sure many of you are familiar with them. And then really look at the study and solutions. So in terms of the economic impact of quality of life, there's been a couple different studies, both done in Canada and the US and the UK specifically. There's a new one that's being done in India as we speak. And what we've found in each area is that the gluten-free products were statistically significantly more expensive than their wheat-based counterparts. In the Canadian study in particular, they looked at the two main grocery stores across Canada and found that the products were 240% more expensive than the usual wheat-based products. In a study we did here in the States, we used a market basket approach, which is what the USDA does in terms of determining the cost of food for the gross national product and things. And we compared not just two main chains, but we looked at the different venues where people get gluten-free products. We looked at the regular grocery store, health food grocery store, online purchasing, and specialty markets, in addition to looking at different regions across the state. And what we found is it was kind of a mixed bag. Indeed, gluten-free products were 183% more expensive, again, statistically significant. The good news was that when we compare it to a study we did back in 2005, that's a reduction from initially over 240% more expensive as well. What was interesting in our study, we found that when we looked at the mass market entrance into the world of gluten-free, with major wheat-based brand companies coming in and producing gluten-free products, that even though it increased availability, those products were still significantly more expensive than their wheat-based counterparts. An interesting twist on this is a study that was done out of the UK, in which they also looked at the comparison of the two products. And what they found is, based on whether it was a regular grocery store, a budget store, or a corner shop, that the foods were still more expensive by up to 124%. And why that's an interesting twist is that at the time of this study, gluten-free products were still on prescription in the UK, which meant that someone diagnosed with celiac disease was given a prescription, and some of the cost of that food was underwritten by the government and the health insurance. And even with that, the products that people would buy off prescription or needed to fill in from that prescription were still significantly more expensive. As we said, we did a comparison from our earlier study in 2006 to today. And one of the interesting things we found is there was a shift in availability, where previously you could get anything you needed online. And it would be interesting to go back and revisit this now during our pandemic time to see if that has shifted yet again. The good news is, though, that the availability of gluten-free products has significantly increased in the regular grocery store, so that the availability has indeed increased in the local market compared to back in 2006. Another concern, another impact that we need to always think about when we think about the gluten-free diet for our celiac patients is the nutritional balance of the diet. And two main areas have become more and more of a concern. One is the micronutrient deficiencies of the diet and the high degree of fat and sugar and the obesity rate among our patients. In a study done on the micronutrition deficiencies, it was found that there were reduced levels of zinc, ferritin, vitamin D, folate, and B12 in the study population. And the BMI in this group with micronutrient deficiencies was in that overweight range. In the study that looked at the 149 pediatric patients, and so not many studies done in peds patients, we found that the BMI measured at diagnosis and 12 months increased dramatically, and it increased even for those that were already obese. And those that were overweight, actually the number of patients that fell into that overweight category doubled. So we can see this a big impact here. Another study that looked at the obesity rate in our patients actually looked at how many patients changed their BMI score before diagnosis to after diagnosis. And we found that the mean BMI in the whole group of patients did increase from 24 to 24.6, which is, you know, when you change those categories, it is statistically significant. But really a concern is the number of patients that increased from the normal BMI range to either overweight or obese, which was 17%, or those that went from that overweight range to the obese range was 17.3%. And that was a concern in that we're really seeing this major shift in body composition. What I want, oh, sorry, it bounced. Let me go back. Sorry. There, I knew I missed a slide. So what does this bring us to? And when we look at celiac disease, we know that diet is the only treatment for celiac disease. And when we look at not just the quantitative data of the nutrition content, the cost of the diet, we also have to look at the treatment as being much more complex than that. And it seems simple, and when you initially say to someone, you just take gluten out, it's like, well, that's an easy fix to do. But we also need to really teach our patients it's much more complex than that, and we need to be aware of the multifaceted aspect of it, is that taking gluten out isn't like removing salt from the diet or fat from the diet. It actually impacts, cross-contamination, exposure causing damage, but it also impacts our family, our culture, our social life, our traditions, and that's something that we as dietitians need to be acutely aware of. We also need to realize there's a ripple effect to this change in the diet, and it affects, one of the studies we did on families is we looked at the person being diagnosed, how did that overall impact the family and what were those changes that were made. And we found that there was a measured increased burden in the mother in particular, parents in general, but in the mother in particular, when a child was diagnosed with celiac disease. We also found out that when a child is diagnosed with celiac disease, it impacts directly food traditions, food cultures, and has that ripple effect both to siblings and to grandparents. And the ripple effect was both producing barriers as well as motivators. We found some grandparents were now much more eager to provide gluten-free healthy snacks for the kids, or others were not willing to take the challah off the Shabbat table. So it really was, it went both ways. And this leads us into the study we did, some of the other studies on quality of life, where we look at not just this ripple effect, but the global effect, that whether the study was done in Italy, in Sweden, the UK, Canada, or the US, we're finding that that effect has, the negative effect ripples through one's life and one's families. In the Italian study, it was, really after 6 months of being diagnosed, both the patients and the family reported really feelings of anger and anxiety at the burden of following this diet. In the Sweden study by Svecker, it was a great qualitative study. He really found that emotions and relationships and daily life were the key things that were being affected. In particular, it was like unwanted visibility. Many of the things we'll see in the hypervigilance study as well. The study out of the UK with Barrett is found that 80% of their patients said the diet was just difficult to follow. So it's not even, the major point he found is that people just struggle with trying to maintain the diet. In the Canadian study by Craney and her team, they found that, again, it was 90% reported, or 83% reported trouble with the diet, but actually it were people that no longer traveled, no longer went out to eat, that really changed their social life and their relationships dramatically. In the study that we did early on, we found that the social domain was really the most negatively affected, and that persistence lasted over time. When we think of that global aspect of it, there's been a few newer studies that really also in emerging markets for gluten-free. In India, we see that the quality of life decreased after 6 months, similar to the study done earlier on in Italy. In Hungary and Romania, they found that the impact was, on lifestyle, where it was that ability to be spontaneous and dine out, grab a coffee, meet friends, but also finances. In particular, the price and availability of gluten-free foods in Hungary was noted as one of the primary barriers to adherence on the diet even. In a study that was done with a 10-year follow-up in the UK, they found that over time, from diagnosis to the 10-year follow-up period, that the quality of life score was decreasing over time instead of getting better. What this does is, as we can see in this graph, is that we really find not just a global aspect of the negative impact, but we see a persistent negative impact of the gluten-free diet on quality of life over time. That even when we look at that 10-year mark, even though initially we're finding that the ability to dine out and travel gets better, it's still 30% of most of the studies, the patients reported difficulty in dining out and travel. And when we think of that this is a lifelong treatment, that really has a residual effect on one's ability to navigate life in a social way, and it impacts their quality of life dramatically. So which brings us to the study that we recently did. And why these all lead up is that every time we do a study, we ask more questions. And we say, okay, if there's this persistent negative impact, how, what are those aspects of that negative impact? What's driving that reduction in quality of life? What's driving that resistance to be more social? So we did a cross-sectional prospective study of both teens and adults in biopsy-proven celiac disease participants. We used both the specific quality of life study, the CDAT, which is a knowledge-based and validated food label quiz that we used, and we did vigilance based on a 24-hour recall interviews and using that knowledge-based quiz as well. We also had many open-ended questions to identify those facilitators and barriers to the gluten-free diet. And again, this goes back to that ripple effect, looking at how does it impact you, the individual, but also those around you in your social sphere. And what we found is that, we should explain first how we categorized vigilance. It was on a scale of 1 to 6, 1 being excellent adherence, and 6 being not following the gluten-free diet. We looked at 3 24-hour recalls, and we based the vigilance score on a 10-point, on a 1 to 6 basis, based on whether the patient reported asking thorough questions when dining out, eliminating any potential cross-contamination in the kitchen, using only gluten-free restaurants versus those that have a gluten-free menu versus a regular restaurant, and then categorize those. An adherence score of 1 was ranked as extremely vigilant. So we looked at adherence and vigilance both. What we found is that there was a 10-point difference in scale in adults. Those that were extremely vigilant had a 10-point lower quality of life score, which was significantly different. We found that it also wasn't just the general quality of life score, but also those subcategories. What people reported is they felt more limited, they felt more overwhelmed, more concerned about lack of treatment options, and just really that overwhelming feeling of that it's just difficult to constantly have to navigate the gluten-free diet. And statistically significant in this is a shift of 10 points in the overall quality of life score. What was interesting is even though we saw a negative impact on quality of life scores in the teens, it was not statistically significant. There was a shift, but a much lower shift. The other aspect that we found in looking at the vigilance scoring is that those patients that scored higher knowledge on the quiz on label reading and understanding gluten-free diet also scored lower in their overall quality of life. They scored higher in the feelings of being limited, and they often reported constantly checking labels and menus and rereading and re-asking questions. When we look at some of the qualitative data, this is where we found more negative impact in the teens than in the adults. The adults, pretty much the impact was just that overall quality of life score, where in the teens it was more in the qualitative areas of eating out and in trying to identify gluten-free products. We found that the teens were constantly relaying that they were frustrated, that they found restaurant staff dismissive or uninformed. They found that it was really difficult to plan ahead or to ask the questions, especially when they were out with their friends. It was interesting, we didn't anticipate this in the study, especially coming from the teens, that they really found, and some of their comments were quite curt about the labeling of gluten-free products. They really found that they would bring in boxes saying, this says gluten-free, but then it says on the back that it has wheat, or where they really found the misbranding leading to mistrust of labels, but also they seem to take it as a personal affront that these things were not labeled appropriately. One young man said, if I'm supposed to be able to be adherent to this diet, people should at least label things appropriately. Overall, we found that 56% of adults and 70% of teens reported that negative impact of the gluten-free diet. When we look at areas of cross-contamination, I brought this up for you, Vanessa, because I think this will lead into your study, interestingly, is that we found that those adults that scored as being extremely vigilant, that 41% of them reported being concerned about cross-contamination. Even though the teens reported in their qualitative data such big impacts on being worried and trying to navigate dining out and issues with labels, only 28.6% of those that were classified as extremely vigilant did say that they were concerned about cross-contamination, which is almost the opposite of what we would have expected. Probably one of the biggest areas that I want to focus on is, because the data is very interesting. It shows that consistent negative impact. It shows that, being concerned and being more attentive does negatively impact the quality of life. But when we look at some of the qualitative data from the open-ended questions, I think this is what highlights these real specific areas. And this is where we as dietitians need to take this information and really incorporate ways to counsel our patients so that they don't have these negative impacts of the diet. One area is that social exclusion. We found that almost 36% of the general population in this study felt afraid to eat out because of cross-contamination. One of the statements said that, that people hated being the center of attention at the table. They didn't want to have to be the one always asking questions, always being the one to be served first or differently. We also found in the area of family and friends that many of the participants reported that the family and friends didn't really understand the need to follow the diet. 47% felt they also felt limited in eating with coworkers too, that eating at work was difficult because you had it was hard for people to understand. Some of the comments here that really were very telling is that one aunt told one of our young teens that, well, I don't see anything happening to you, so it can't be a big problem. And so the feeling is that because they can't see a change, they can't see a rash or reaction or something, that it must be in their head, this, feelings that they have after they're exposed to gluten. And that lack of understanding by those family members was really very devastating. The lack of social spontaneity was another thing that really reverberated back to Specker's study and some of the other UK studies, is that, over 35% of people really felt limited in the things that they could just get up and do. They couldn't just go out and grab that slice of pizza for lunch with everyone else. They really couldn't just, decide to pick up dinner on the way home without really checking things first. The other thing that was, to me, very poignant was the quote by one of the adults that said, the times I get invited out to meet with friends has become less and less because their friends don't want to eat with what they call a fussy eater. And so this was one of the young adults that really felt that her social life and her ability to dine out with friends was becoming more and more limited as they got really frustrated with her constant questions and things. When we think of, this qualitative data, we have to really think of this in terms of this is the real life of our patients. And, it is that social domain, but it really, again, hits home to, that the social ability of people, the ability of people to be social, that use of knowledge and have the constant vigilance that's required, and the feeling of being left out. And these are just a couple of the quotes that we have that I picked up that, people's reaction changed to this one individual when they couldn't eat certain foods, and how hard that would be for a teenager to be eating out and really be ostracized at the table just because they need to follow the diet. Interestingly, when we talk about where some of this vigilance came from is where the participants reported that they felt like they had to keep explaining to people what gluten was, why it was important, why they couldn't cheat, why they just felt like it wasn't where they could say it once and explain it and they were done. That even with their family members, they had to constantly keep reminding them what it was. And the feelings of being left out. One mom reported that, she will order pizza for the family, but she just ends up eating a bowl of cereal, and how devastating that is, that she can't even partake in that, family meal. So what does this do for us? Some of our key takeaways is that we need to remember that food is more than just what we eat. It's social, it's cultural, it's traditions. And we need to, when we educate our patients, is to really think about, addressing not just the do's and don'ts of the gluten-free diet, but how to navigate those changes, how to incorporate the gluten-free diet into customs and traditions that are routine. We also have to be cognizant of that we need to give our patients the time to process this change. It really reflects back on Prochaska's, stages of change, and there will be that time of mourning for that gluten-free pizza, the feeling of anger and anxiety. And our job is to get them to relief, and to really help them, find their support systems, to help them kind of find their tribe of people that will support them and encourage them. We also need to realize that the treatment needs to be very much individualized. We're realizing we need to take a more holistic approach. I have started, especially during this time of COVID, I've started talking to my patients more and more about, you need to do yoga. You need to take a walk. The increased stress is going to affect your gut. So not everything that you're feeling from your GI system is necessarily a gluten exposure. It may be other things. And we need to, encourage our patients to see that too, that anytime they don't feel well, it doesn't necessarily mean they had a gluten exposure. It may just be the rest of life that's happening. And indeed, we need to, one of our favorite quotes from our team here is that it's really an approach from cell to psyche. It's everything from that we need to be adherent and encourage our patients to be adherent, but not at the risk or the deficit of our emotional health too. So, what we aim to do is that we know gluten-free diet is for life, but it's meeting more than just nutrient needs. We need to educate and counsel to make the gluten-free diet easy to fit within cultural and family traditions. Our goal is for the family to eat together and enjoy all those social events, and to make it more than a restriction, but a positive way of life. Thank you.
All right, thanks, Anne. If you can just kind of if you stop sharing your screen, I think we'll let Vanessa do her, she's just going to do a brief overview of the studies she did, and then we can do the discussion after.
Okay, there.
That was awesome, though. Thank you.
All right. So that was a very good introduction into our study looking at cross-contamination in shared kitchens. So I want to just sort of start out by why we did these studies. If you look at the recommendations that organizations that we all belong to, the different celiac advocacy groups put out, they're very strict. And as Anne mentioned, a lot of these recommendations could lead to hypervigilance and reducing the quality of life. I'm talking about things like we tell our kids that they can't use Play-Doh at school or participate in lots of very common activities in the classroom. We tell our families that they have to have 2 toasters. We say you have to have dedicated gluten-free pots, pans, cutting boards, and all of the different utensils. And then we tell them they have to travel with all of these things. So, just thinking about the types of things our patients travel with, they tell us that they feel like they're in a clown car. Or my favorite was one mom who said that every time she went on an airplane, she felt like she was carrying an elephant on with her. She said she had no problem checking their luggage that had clothes in it, but they would carry on the pots, pans, and toasters, because if they lost the clothes, they could easily get new stuff, but they needed to be able to feed their son. And so that visual of the elephant has always stuck with me. So I put together some of the recommendations that these groups put out there. So NASPGHAN says, purchase a separate toaster for gluten-free breads, or use a toaster oven that can be cleaned between uses, or place tinfoil on the rack to avoid contamination. So again, we need to be separate, or we need to be very vigilant. Beyond Celiac says that we know you cannot use the same toaster for both gluten-free and gluten-containing items. Cutting boards are also a problem, but the most shocking, handles of the kitchen any handles in our kitchen can expose us to gluten, which now makes me afraid to touch anything in my kitchen. And finally, one of the notes I pulled from one of our GI providers notes, I recommend a separate toaster as this may be a source of contamination. So the education that we as professionals are providing is hurting these people. And as Anne said, the higher the knowledge, the lower their quality of life was. Yet these people are getting education in many cases from us who are supposed to be the experts and from these groups. And so it just leads us to remember that we need to be really careful about what we're suggesting and make sure that the recommendations we're given are based on something. So the current recommendations that all of these groups are putting out are not based on data. They're based on what we think was the right thing to do. But we want to be really confident, and we want to make sure that when we're making these recommendations that they're actually what is going to keep our patients safe. So we did 2 studies. I'm just going to talk about the kitchen study today. The other one was in regards to schools. We wanted to quantify gluten transfer from gluten-containing to gluten-free pasta, bread, and cupcakes that were prepared in a shared environment. And then we wanted to look at cleaning and whether or not we could clean the equipment in between use to make it safe for both gluten-free and gluten-containing. And then thanks to Ritu Verma at University of Chicago, we wanted to see if we could rinse pasta that was previously contaminated to get rid of the gluten. So I want to just lead off by talking about how we measured gluten because we have gotten probably the most questions about that. So all of our samples were packaged in clear plastic bags with randomized sample numbers and were shipped to BIA Diagnostics in Vermont, which is one of the leading laboratories that does gluten testing on food products. The gluten was assayed in homogenized samples, so we measured the full amount of gluten in all of the different foods that we tested, and they used the R5 ELISA for all of the detection. So I'm going to go through the scenarios really briefly. So we started with pasta. We cooked gluten-containing pasta in clean water. We then discarded the gluten-containing pasta using a handheld strainer, but we kept the water. Then we put gluten-free pasta in the water that was previously used to cook the gluten-containing, and we had 2 separate experiments, one with fusilli and one for penne, to see if the shape of the pasta made a difference. Then we divided the cooked pasta into 2-ounce portions and homogenized the entire portion to measure the gluten. And here's what we found. In every single case, there was no question, cooking gluten-free pasta in water made previously with gluten-containing leads to cross-contamination above the 20 parts per million level. So here we have 12 samples, and I don't think I need to show you any additional samples for us to all agree that we should not do this. So then we started over and we cooked gluten-containing pasta in clean water. Then we discarded the gluten-containing pasta and the water. We washed half of our pots with soap and water, and half of them we rinsed with just water alone. Then we put new water and gluten-free pasta in the pots, again, half fusilli and half penne. And we divided it into the same 2-ounce serving portions and measured for gluten. This time, we had no cross-contact. So this shows us that cooking gluten-containing pasta, but then washing the pots that they're cooked in, and then using clean water and gluten-free pasta, we can have food that is gluten-free food that is safely prepared in shared pots. So then we wanted to see, can we rinse the pasta? So we started over again and we cooked gluten-containing pasta in the water. We got rid of the pasta, but we kept the contaminated water. Then we added the gluten-free pasta into the water and cooked it. Then we put it in strainers, and using a handheld sprayer, we rinsed the pasta and then divided it into the portions to test for gluten. And again, we found that there was not levels of gluten greater than 20 parts per million. However, we did have this one sample that was leading up to the 20 parts per million, so in no way would we recommend doing this right now, but it was really interesting as a potential method to continue studying for how we can remove gluten from food if it was previously contaminated. The other thing that I wanted to just briefly mention was that we did see a big difference between the fusilli and the penne. And so we went back and tested the level of gluten in the water, and the water was identical. It was in a couple of parts per million per pot. So that does lead us to believe that the surface area of the pasta does play a role in how much contamination, although all of them were greater than 20 parts per million. So it really doesn't matter in the long run. So then we went on and looked at shared knife. We sliced frosted wheat flour based cupcakes with a knife, and then we reused the same knife to slice gluten-free cupcakes. We then assigned cleaning methods. So we washed a third of the knives with soap and water, a third just rinsed under running water, and a third we cleaned with a wet ones antibacterial hand wipe. And then we took a new gluten-free cupcake and sliced it with the knife to see if there was still cross contact. And then, of course, again, we homogenized the entire cupcake. So this is just a photo from the day where we did the experiment. Laying on the table on the napkin, you see the gluten-containing one. So there was lots of frosting and crumbs, and then the gluten-free cupcake being sliced next to it. So the blue lines are before washing. And so you see we did have a couple of them that crossed the threshold, but lots of them that were very close. So again, we would never recommend using the same knife without washing to slice a gluten-containing and a gluten-free cupcake. But then the green lines are after washing, and this is the breakdown of the different methods of washing. Surprisingly, the wet wipe was actually the best, and we think that that's because all of them were less than 20 parts per million after cleaning with the wet wipe. But we think that's because we had actual friction of the wipe touching the knife and pulling it off. There was not a big difference between water alone and soap and water, except for that all of them reduced the transfer to less than 20 parts per million. So toasters is perhaps the one that has been talked about the most. So we tested slices of gluten-free bread in our hospital cafeteria toasters. We have a series of rolling toasters that are available for anyone who enters the hospital to use. We toasted slices of gluten-free bread in 20-minute intervals so that there was lots of toasting of gluten-containing in between. We also tested using pop-up toasters where we toasted gluten-free bread immediately after toasting gluten-containing bread for 5 days in a row. And there were crumbs in both toasters, which this was one of the rolling toasters that we use, and you can see tons of crumbs that the bread fell into. And then this was one of the pop-up toasters that we used. And as you can see, not one approached the 20 parts per million line. The 4 samples that we did have detection of, they were 5.1 and just around 8 parts per million. And those were all in the rolling toaster, but the pop-up toaster had no detectable levels of gluten in any of the samples. So, at first we're like, this is very surprising, but actually our results agree with another study that was done by Diana Studaris' team, where they looked at contamination with common kitchen utensils, and they found very similar things, that cross-contamination could occur with kitchen utensils, but may not be as relevant as we previously thought. And that these practices may not pose as much of a risk for celiac patients as do eating pure wheat flour or breadcrumbs. And again, this is my favorite sentence of their paper: overly restrictive recommendations and scaremongering is inappropriate. And that's exactly what we found, and we think is really important for us to remember. So what are our conclusions? So far, there's not a ton of data. We've done a pilot study, and it agrees with studies done by others in the past. Some of kitchen activities pose a much higher risk, like cooking pasta in the same water, than perhaps toasting does. And that perhaps a dedicated set of equipment is not entirely necessary. And obviously, we need larger studies, which is what we're working on right now. I'm going to get to the larger studies in just a second, but so we've been asked a number of times on how we use this information in our clinic. And so we've tried to really shift the conversation to focus on avoiding and limiting the risk of exposure, but not to the extent that avoiding gluten leads to unnecessary anxiety, severely limits what your family does beyond what is necessary to protect yourself, and that hypervigilance has become such a huge issue for our families that we want to try and reduce that as much as possible. We think that this study is a reminder that we have to shift the conversation to think about food choices and activities based upon risk. And that we have to understand which activities have a higher amount of risk and which of those can be reduced by things like washing and good hygiene and the type of activity where you are. It's very different being at grandma's house versus being in a busy restaurant or a cafeteria. So as I mentioned, we're currently conducting a multi-center study at 6 different sites across the country. So far, we have already tested 196 more toaster samples. Half of them were frozen bread, half were shelf stable, half were pop-up, and half were toaster ovens. All continue to be less than 5 parts per million. We've tested over 100 pots and pans, half stainless steel, half nonstick, all less than 5 parts per million after washing. The same with colanders, the same with cutting boards. It didn't matter wood, plastic, or glass. And in this study, which is different from the first one, we're testing 1 gram samples run in triplicate, which is 3 times what we tested in the first study. So we're really working to make sure that we are not missing gluten and that we can in the future make really strong recommendations. So with that, I will stop so that we can have a few minutes for a conversation.
Yeah. Vanessa, actually, if you want to just go to your questions, because I think they link the two topics pretty well. So, given how we know that this hypervigilance negatively affects our patients, I like your first question a lot to get started. What results do we need to see to globally change recommendations? And everyone, feel free to unmute yourselves and chime in. All right. I've actually I unmuted all of you in case that works. All right. Well, Anne, maybe you can get us started on this.
Okay, right. I just turned off the air conditioner so it wasn't so noisy. I think what we need to see, I mean, Vanessa, the study is just outstanding, and it's so important because what we need to see is that if we have data where we can really identify that that these practices are unnecessary, I think then we can change how we educate. And so I think having that data showing that there isn't that cross-contamination or that leap, as one patient told me the other day, that crumbs leaped into her food, that's not happening, that I think that's going to change the recommendations. I really do. I think if we can document that, washing things is sufficient, it will diminish that anxiety.
Yeah, and I agree. And one thing, and kind of gets with your third question, is people are really scared that this is going to lead to people not paying attention to their needs, and that they're going to get sick because people are just going to think, oh, well, I washed it, so it's fine, and not necessarily take the necessary precautions. And so I think, the education, you need to kind of convince the healthcare providers, the dietitians and doctors working with these patients that, they need to start from the beginning, educating these people correctly. And I think a lot of times people aren't following up with a dietitian. So partnering potentially with, Celiac Disease Foundation and other organizations like that, like the Beyond Celiac, that recommendation surprised me about the refrigerator handles.
I now think about it though every time I go to my refrigerator.
Right, I get it. Yeah.
But to me that's so scary because the likelihood that you're going to get crumbs from the refrigerator handle, and that for people to be so fearful even within their own environment, I think we are just, as you said, Megan, we need to do a better job of educating awareness, but not anxiety. I think it's where, the diet is the diet and you need to be careful. And it doesn't mean that you can cheat. It just means that you don't need to be hypervigilant,
Mm-hmm.
It was really interesting seeing the feedback we got on social media, emails that came into our hospital directly, and just the conversations that happened in a lot of Facebook groups about the studies, and how many people there were who really didn't want information about how what the data shows. They were more insistent. They thought that this study would give their family fuel to be less vigilant and to not take them seriously on how they want to be handled. So as opposed to we saw on the flip side that this was great information to show your family, to say why this is important, that you wash things well, and we're not using the same utensils on gluten containing and gluten free. But they felt that it was us giving their family the freedom to do whatever they wanted when they come to their homes. And so they would rather their recommendations for how they see their diet be what's followed, as opposed to science. And so I think that's really hard to undo in people.
Yeah.
Vanessa, I think your research is amazing. This is
Yeah.
super exciting. As a celiac myself, I'm like, wow, this is great. I also think that, I understand their concern that people won't be taking it as seriously, but at the same time, if there's less things to worry about, then there's less things to be overwhelmed with, less questions or concerns that they have to ask. And people will probably be more likely to be able to be compliant if they don't have as much to worry about. And I think when I saw this the first time, I was like, I kind of feel like the toaster matters. I don't know, but I obviously see your research, but it's like hard to, you see all the crumbs, and if we say you don't have a crumb, but there's crumbs all over the place, it's hard to say, oh no, the toaster is fine. But the fact that, I know you're not finished with the new one, but the fact that you're finding none of them are, above 5 parts per million, then it's really must not be happening. I guess it would have to really stick to the bread.
I'm glad that you brought that up, and I want to talk about that for just a second. So we've run, now close to, well over 300 samples of toasted bread, and have had not one come back with contamination. The only 4 we had, period, were in the rolling toaster that were those 5.1 and 8 parts per million. And so Jocelyn Sylvester and I started being like, okay, we need to see, can the lab actually detect gluten at these levels? And so we've now started piping in really tiny amounts of gluten to our samples, to some of the samples, to make sure that the lab is detecting gluten appropriately. And so we had it run in our in-house lab at Children's National, and then we also sent them to the lab in Vermont. And all of the samples they did detect it in, except for 1. And so because of that 1, that's actually why we changed our methodology in the second phase of the study, in running 1 gram with in triplicate, was because we know that that's when we can catch it. And so that was where that sample got caught. And so we wanted to make sure that we're definitely not missing it. And if you think of how we test food, they take a portion of a loaf of bread, or they take a portion of something that's sent to them by a food manufacturer, and they spin it down, and they take a 1/4 gram sample out of, what could be a 50-gram loaf or a 100-gram loaf, and then they pipe out a really small extraction from it. So if we just try and think about how you can uniformly homogenize a crumb that's barely visible to the eye, it's really hard to imagine how they get it. But thankfully, we've been pleased, and in most cases, they've been able to do it well.
Have you discussed testing bread that's toasted on a grill that's had, pancakes or French toast or anything like that on it?
We have not done that yet, but that's a great idea to do. Right now, we've just focused on toasters because we really want to put that issue to bed.
Yeah.
That, we would never recommend it in a cafeteria or a hotel, but in an environment where you can look at it, like grandma's house, a friend's house. We want to reduce the anxiety around at home and within the family unit. And then common things like colanders and pots and pans.
Yeah.
And cutting boards, because the whole wooden thing we want to put up to bed too.
I know
Anne and I have also discussed much more complicated ones that are not probably, I know with the technology, it's not as easy to test, like with the fryers and the fried foods. I don't know if there's been any headway on any of that kind of stuff.
There's been a lot of discussion on it, and where we've gotten stuck with it, and maybe this is something that we can all talk about, working on together, is how to control. because it's impossible. Like, sure, we could go out one day and collect a bunch of samples from, McDonald's, Burger King, Chick-fil-A, all the different places, but there's just not really uniform practices amongst them in terms of, if the fryer's down that day, what else went in it, or how was the food handled getting it there, and being able to test, the still frozen product. It's really hard to do all of that without the restaurants themselves participating in it to give you access to that information. So it's very difficult to control. We've met with lots of different restaurants in the DC area, and their practices are so different based upon the day or what the specials on the menu are, that it's really hard, or at least we haven't been able to wrap our heads around a way to make a really good statement based upon what we get back from the data.
Got it.
It would be interesting. I mean, for a study, you want to have it, a standard method and everything, but the other part of me says if you went and randomly went to 50 different restaurants and just sampled their fries, it would give you a very real life of what, what is that potential gluten exposure. And I think in some ways that may be what we need. I love that you've documented the pots and pans and fine, and that you don't have to worry. You can go to grandma's house without your elephant trunk of pots and pans. But the fryer question, I think, is a stumbling block, but I think it's one that, maybe we look at that differently and just do that real life experiment, where if you randomly check fryers across the country, what does that mean? Of potential gluten exposure.
Yeah. Because I know that's one of the first things people are asking, like, do I really have to care about fryers? And as of now, I'm like, yes, but I don't have the evidence to back it. So having that actual evidence, obviously everything's individualized, but as of now, that kind of seems to be what, the recommendations, but we don't really know if that's
we have no idea.
Right.
Yeah.
Right. Exactly, to Vanessa's point, our recommendations are based on of practice, that because we just didn't have data when we started all this, is like it was the assumption that crumbs matter. And I guess based on kind of reflecting back on the old oat studies that were done, even trying to determine the amount of oats that were safe, the data isn't there, so it was assumptions based on perceptions of best practice. So,
and we actually started doing this work. So Anne and Megan worked with us on the school guidelines project, and this all started because when we met with the Superintendents Association and the National Association of School Nurses, they said, sure, we'd love to be involved with this, but before you tell us that we can't use Play-Doh or that we have to get different materials, we need some data to show that this is actually a problem, not just like guides from places saying don't do it. And so that was really why it started. And when I'll never forget Melinda Dennis from the National Association of School Nurses looking at me and saying, I need actual data, and just being like, oh my God, we have nothing. So it was very eye-opening.
Yeah. And just sort of on that, I kind of want to pose another question tying in one of Anne's questions, which was, should we change our counseling of individuals with celiac disease? If we're trying to promote an atmosphere of, not making them so scared to ever dine out, and, keeping in mind these recommendations, what do you guys think about that? And in your experience, I know Jessica and Anne, I'm curious to know if you've had to adjust based on, these types of studies.
Yes, which is the good news. It's been wonderful to say, listen, you don't need, we haven't gone to toaster yet. We want that final set of data. But in terms of cutting boards, colanders, pots and pans, I have completely changed and just tell them they need to be washed. I also caution that not everyone washes the same way, that if they have someone who is like a rinse and fling kind of person, that, maybe wash it again. Or if you're in a college dorm, I've talked to people that if they're in that shared college dorm kitchen, they may want to wash the pot before they use it, but they just need to wash it. That's all they need to do. And it's been great to be able to say that.
Yeah, I used to bring up the toaster frequently, and now I'm like, wait, no, I mean, what am I telling these people? This might not even be right. So now I really don't bring up the toaster unless there's like, we're digging so deep and there's a real reason the toaster will come up. But, you know, as I'm sure Anne would say too, you know, in practice, everyone is so individualized, which is what I find interesting with this research, but also hard because I feel like there are certain people who can be so much more lenient. Their antibodies can be fine. Their symptoms can be fine. Their endoscopies can be fine. And they could, you know, not even bring up at a restaurant that, you know, that they need a gluten-free meal. And then there's others who are so sensitive from what they're reporting, you know, to gluten and contamination. And, you know, obviously if you have more severe symptoms, that there's going to be more fear around what they're doing. But even still, it seems that they have to be a lot stricter to have their antibodies and to have their intestinal healing and their symptoms under control. So, you know, obviously we have quantitative data here of where is there gluten or where is there not, but it's interesting to see how that will be interpreted for each individual case.
Yeah.
I think some of it's I think we'll have to, as we really individualize our education for our patients, is we're going to have to use, and as I'm saying this, I'm thinking, again, we don't have great data. We use their antibody levels. But it's been said in numerous studies that the antibody levels don't always directly reflect, you know, what's happening intestinally. So again, we're kind of using data as a benchmark that may or may not be absolutely reflective of what's actually going on from a disease state. I think that this may be a wonderful start to really looking at some of our practice assumptions.
Yeah, I wonder if there would be a way to see, you know, symptoms from having the bread that you're doing in the toaster and seeing how people respond. Do they have symptoms to even that below 5 parts per million after it's come out? You know, can we attribute that to gluten, or are they having symptoms all the time? Is that enough, you know, quantity for even anything to be experienced? So there's so many layers that also don't have so much data to go along with it.
Right.
Yeah, absolutely. Vanessa, I know you have a patient at 2 o'clock. I'm sure you guys are all busy. So if we just I kind of want to wrap up, but thank you so much for coming. This was fun. I'm hoping to do more of these coming up in different topics. So hopefully we can do it again.
Absolutely.
Thank you. It was a pleasure to be part of it.
Yeah.
Thank you.
All right. Thanks, everyone.
Thank you, everyone.
Thanks. Okay, bye.
Bye.